So before we start, we will kind of have yes. Hello. Okay. Okay, so before we start, we will kind of give a little bit of introduction of our speaker, and I'll have Angie kind of go through this, and then we'll go through some housekeeping rules, and then we will head up into the talk. So as we all know, this is a talk about understanding perimenopause and menopause, facts and tips for the midlife woman. I guess even though it's for the midlife woman, it's also for the men who are in their lives. And so it's important for all of us to understand this as we kind of are all inching towards this aspect of our lives. And so, Angie, I'm going to, please, if you are not speaking, can you mute your mic, please? So Angie.
Okay. Well, thanks, Jonah, and good everybody. Welcome to this international Zoom meeting. Just say that we have both medical and non-medical participants from all over the world who are here and who will be joining us as we go along. So to bear that in mind, it's my pleasure to introduce my sister, Dr. Ya Asamoah Amankwa. She's an obstetrician gynecologist at the Ottawa Hospital and assistant professor at the University of Ottawa, Canada. Ya attended the University of Ghana Medical School as a member of the class of '97, and then completed her residency in obstetrics and gynecology at the University of Ottawa, where she undertook training in mature women's health. That's why we are here this afternoon, because of her expertise and her training in mature women's health. In addition, she obtained specialized training in the management of vulvovaginal diseases at the University of Michigan Center for Vulval Diseases and the Mid-Pathology and Research Clinic in North Carolina. She has publications in the field of vulvovaginal disease. Miss Ya, take your time and let's
I increase the volume.
Me? Angela needs to increase her volume. Hello?
Yeah.
Can you hear me?
Yes, yes.
Okay. Wonderful. So can I continue?
Yes.
Wonderful. So Ya has 12 publications also in the vulvovaginal diseases, and her practice includes both obstetrics and gynecology. She's part of the obstetrics core group at the Ottawa Hospital and provides specialized care in women's health and vulvovaginal disease at the Ottawa Hospital. Dr. Amankwa is a passionate educator.
I know you have something to do like this.
She was director of continuing medical education for the Ottawa Hospital's Department of Obstetrics and Gynecology for 10 years. She has been the chair of several planning committees, organizing conferences to educate primary care and provide and OBGYNs on women's health topics. She has received awards for education from the University of Ottawa, as well as National Faculty Award for residency in the American College of Obstetrics and Gynecology. It's my pleasure this afternoon to present our teacher, our speaker, our guide extraordinaire for perimenopause and menopause facts and tips for the midlife woman, Dr. Ya Asamoah Amankwa. Miss Donna, I'll hand over now, yeah.
So before we have Dr. Ya Asamoah on, a few housekeeping rules. So please mute your microphones unless if you are speaking. And then we are going to have this in sessions. So she will talk about different topics, and at the end of each topic, we will have questions. And you can use the chat feature to send your questions in as she's speaking, so that we can collate the questions and have everybody's questions answered. We may not be able to accommodate all questions due to time, but we'll try to answer every question as much as possible. So as she's speaking, if you have any questions, please use the chat feature to ask your question. Thank you, and I will have the speaker take over now.
Well, thank you, Jonah and Angie, for the great presentation. Welcome, everyone. Thank you for the great opportunity to share my knowledge with you. All right, I'm just going to share my slides shortly.
Yes.
My connecting we answered. It was some me charging.
All right. All right. So why this talk? Can you see my slides, everyone?
We can, yeah.
Yes,
yes.
Perfect.
Yes.
So sadly enough, despite the excellent training I received at UGMS, this area of medicine was an untraveled terrain, if you would agree with me. I don't ever recall getting
Jora, you probably need everybody
everybody,
except
yeah.
yeah.
Yes,
Yeah, you have to mute
Yeah.
everybody
Mute
except
all.
yeah. That's the only way.
Yeah.
mute all participants, please.
Yeah.
Jenna.
All right. So like I was saying, we had excellent training at UGMS, but this area of medicine was an untraveled terrain. I don't ever recall getting any on this topic. I promise I was not sleeping during class because Koba, my chagrin, constantly left an aroma of goat soup on his fingers after a road trip to, I won't mention where, and this certainly annoyed me enough to keep awake. So I didn't miss that segment. So this was not taught to us. But once I had the opportunity to study further into this area, I felt such a burden with respect to the lack of knowledge women have on this issue and have since found ways of disseminating information. Thanks to Angie, Dr. Eladas, AKA Dr. Sawyer, who asked a question on our class forum and generated interest in this topic for both males and females. So that's why we're here today. So what is a midlife? We're looking at women aged anywhere from 40 to 65 years. So menopause is a one-way road. As women, we will all travel this road and our family members will be passengers in our vehicle. It's luckily some difficulties of menopause can be softened if we have enough knowledge about the disabling problems, and this can be avoided with education about menopause, and that's why we're here. Menopause is a combination of biologic changes that affects each woman in a unique way. Not everyone's experience is the same, and our journeys will be different. Some will have a smooth ride, others may have a bumpier ride. So the outline for my talk today is as follows. So by the end of the session, I'm hoping that participants will be able to understand the definitions and physiology of perimenopause and menopause, identify the symptoms of perimenopause and menopause, discuss the effects of perimenopause and menopause on bleeding patterns, sleep, mood and cognition, weight, urogenital health, and sexual health. And at the end, we also want to identify risk factors for adverse health outcomes in midlife women. So the population, I'm going to use Canada as a reference because this is where I'm based, but I also try to get some information on Ghana. So the population of Canada is about 37 million, and there are about 6.2 million women who are over the age of 55. The population of Ghana is about 30 million, so just 7 million less than Canada, but there are only 1.4 million women over the age of 55 in Ghana. So, you know, I know that the population pyramids are different for different countries, but in Canada, the population as a whole is growing, and the segment of older women is actually pretty, it's growing very fast. And so midlife women's health is a hot topic. As we know, socioeconomic status is a major determinant of health. So if you're listening to this session, irrespective of where you live, whether you believe it or not, you are in the higher socioeconomic class. And with the appropriate knowledge and its application, you will be an outlier with respect to the negative statistics I'm going to be showing you in the next 2 slides. So this is the Canadian population pyramid. As you can see, Jenna, sorry, just a segment. As you can see, the woman aged 50 and over, that bracket of 50 to 59 is actually quite wide. It's as wide as, you know, 3.7% of the population there, just like the age bracket of 25 to 29. So again, this is the fastest growing population kind of comparatively with 25 to 29 age group. And as such, women's health is a big thing.
Yeah, can you show your video? Okay, good.
Is it good? All right. So I couldn't get a clear diagram of the Ghana population pyramid, but look, sadly enough, you can see how it's narrowing towards the top. And so the women 50 to 59 are just like 1.5% of the population. And again, possibly this is why there's not much talk about it, but it is a problem for sure. This special slide is dedicated to the lovely guys in the session with us.
Hasn't been overly physical.
All right. So we're going to look at some definitions here. So what is menopause? Everybody talks about, you know, I feel warm, I'm sticking my head out of a cold window. You don't need someone to tell you what it is. You will experience it when you do go through it. But I thought it will be, we have women in this session who have not been through this, and it'll be nice to give a sense of what this is all about. So when a woman has not had 12 months of, has had 12 months of no periods, what we call amenorrhea, is when she's defined as being in menopause. So mind you, with this, there should be at least one blood work done, because you can skip your periods for other reasons if you're younger. But you know, if you start skipping your periods in your mid-40s, heading on to your 50s, there's no, you don't need blood work to show that. So 12 months of no periods, she has her final menstrual period. So menopause is actually a single day in a woman's life. It is just that final period you have, that is your menopause. But the period kind of surrounding and leading up to the menopause and up to 1 year after that is what we call the perimenopause. So once you've gone a full year without a period, you are now postmenopausal, okay? The average age of menopause in Caucasians is about 51.4 years. However, anytime a woman stops having periods between 45 and 55, it's considered normal, okay? Now I talk about 51.4, but there are variations based on ethnicity, like, and we'll come to that shortly. So just to give you an idea, in women of African descent, menopause may occur later. So it may not be till 55 or 58. And as such, this talk could be very helpful for other people who are still cycling and feel like it hasn't happened. So when a woman stops having periods, between 40 and 45, that is called early menopause. If she stops having periods before the age of 40, referred to as premature ovarian insufficiency. In the past, we used to call it premature ovarian failure, but the word failure is not welcome, so we call it insufficiency. And when a woman loses her estrogen production, it does confer some increased risk of cardiac disease and osteoporosis later in life. If a woman stops having periods after 55, that is called late menopause, and there is longer exposure to estrogen, like, you know, which also comes with its issues. So this is just a pictorial representation of what we're talking about. So menopause being our final menstrual period at the age of 51.4. So if you stop having periods between 45 and 55, that's the average age. Between 40 and 45 is early. And if you stop having periods before 40, that's premature. And if it's after 55, that's late menopause. Now, when a woman goes through premature menopause, that's actually stopping periods before age 40, and let's say she has blood work, a test called FSH, which is follicular stimulating hormone, will be elevated over the level of 40. She'll need a blood test done on 2 occasions. If you stop having before 40 and the FSH is elevated, she's diagnosed with PO. Actually, in the absence of contraindications, any woman who has cessation of ovarian activity before 40 should be treated with hormonal therapy to prevent long-term cardiovascular risks. And this is a big thing that is totally missed and can lead to problems down the line. So what is the perimenopause? So Sorry. My slide is sometimes a bit too fast. So we said it is the transitional period that leads up to menopause. It starts with altered ovarian function. So the perimenopausal transition can last anywhere from 2 to 8 years with an average duration of 5 years before that final period happens. So for some people, it may start in their mid-30s. So if you're destined to stop having periods, by your mid-40s, by your mid-30s to late 30s, you can actually start experiencing perimenopausal symptoms. And the perimenopause continues into that 1 year after the last period. And then the diagnosis of menopause is when you've gone that full year without a period. So this is another picture representation of, oh, my slides are going so fast, sorry. So this is another picture of that final menstrual period right in the middle there. And so that final menstrual period right in the middle there, perimenopause, there's something with the slide, it's just moving quickly. Sorry about that. So you have the final menstrual period there, perimenopause and postmenopause, and the symptoms start anywhere from the middle there. So what happens in the menopausal transition? So the monthly cycles begin to change. So this chart is showing the different stages that a woman goes through, starting with the premenopausal years, and it's followed by the perimenopausal transition, and then the postmenopausal years. So following the reproductive stage, the woman will enter into the transition, which lasts an average of 5 years. The early stage of the menopausal transition is characterized by irregularity in the menstrual cycle. So this is where the periods may start to be about 7 days off from the normal, So if she had a 28-day cycle, she may report the cycle now being, 35 days long from the start of one period to another. And it is during this stage that the hormones begin to fluctuate. And then in the middle stage is it's variable what goes on there. There's changes in the duration and the frequency of the menses, and the amount of bleeding as well can change. And then in the late perimenopause is where you will start to see women skip one or more periods, right? Now, this is not always a progression in a linear fashion, in the sense that women may actually be switching back and forth between the stages. So she can report having perfectly normal periods, and the next thing, in 2 months, now the periods are occurring every 2 weeks, and then 3 months later, she skipped 4 months, no period. And then it doesn't mean that once it starts, you're gonna just start having increasing intervals of cycles. You can be really flipping between monthly periods every 2 weeks, every 4 months, every 6 months, and that's the perimenopausal transition. So it can be tricky there. This is just one point I would like the woman to note. If women start to notice changes in their periods, it's very important to keep a menstrual calendar to document how often the period is coming, how long is it lasting, how heavy is the flow. Because heavy prolonged bleeding in women after 40 can be associated with increased risk of endometrial hyperplasia, which is a precancerous stage that leads to uterine cancer. So if women start having heavy prolonged periods, which is out of norm to what they had before, it's important they get a medical assessment, and it warrants an endometrial biopsy, which is a sample of the lining of the uterus to pick up any pre-cancerous stages, which can be treated, okay? In like manner, another point to note is if a woman goes a full year without a period and then she bleeds, it is imperative that she seeks a medical appointment, because postmenopausal bleeding could signal endometrial cancer, which is cancer of the lining of the uterus. So if you go a full year without a period and you bleed, see a doctor. You need an assessment. You need basically a pelvic ultrasound plus or minus endometrial sample. And the late perimenopausal transition is that stage that's most characterized by the hot flashes, which I will refer to as vasomotor symptoms. All right, we'll do a question and answer period now.
So if you have any questions, please post them to the chat thread, and then we will have them answered. So far, there are no questions. Okay.
All right. Okay.
All right. So there's one. There's one. It says, if one has experienced the heavy prolonged period you described as a possible precursor to endometrial cancer and is fully menopausal now, what would you recommend?
So if you're fully menopausal, you've had no bleeding for a year, then you're gone through that. So there's no need to go get an ultrasound or a biopsy. But when you're going through that is when it's important. So not everybody, again, majority of people that have the heavy bleeding may not have the precursors to cancer, but it is often noted as well. So if you're going through it, get a test. If you've gone through it and you're now menopausal with no bleeding, then you're okay. But if you do bleed again, then you should get an assessment.
Okay, so there are a few other questions, and I will kind of go through a few at a time so you can answer them. So somebody asked again, at what age does menopause start? I think you've answered that, but you can just highlight that, and then.
So menopause is a single day in a woman's life when you have your final menstrual period. But the transition can start anywhere from 2 to 8 years before the final period happens. And the average age is 51.4 in Caucasians and a bit later in women of African. Also, your family history plays a significant role in when your menopause occurs. So if in your family, women stop having periods, in their mid-40s, it's very possible that you can also stop that early. If people tend to go late, you can also follow that trend.
Okay, so the other question is, where can we have the test you mentioned in Ghana?
So do we have any gynaes on the session, like in Ghana? So you need a pelvic ultrasound, which is a basic ultrasound to assess your uterus and the lining. So any gynecologist can order that. The endometrial sampling is often done by a gynecologist as well. It's just like a little, so we put a speculum in the vagina, like you're doing a pap test. And then we go in with a very small cannula. It's like a straw, a very narrow straw into the uterus. It's an office procedure. It takes literally 5 minutes or less. So we go into the uterus, we jiggle it around, and then we get a sample of tissue. So I believe it should be, you should be able to get it with gynaes in Ghana. Is there any gynae on the forum? Like, is Arizona there?
I don't see him. Okay, let's go to the other questions, and then maybe it will be answered later. Somebody said, is the final period heavy or light? And then another question is it normal to be coughing during this period?
Okay, so the final period actually may not be heavy. So for some women, when they start to, there's different scenarios. Some people may say, you know what, I had my normal period, one day it happened and it never happened again. And that was menopause for them. That's very, it's very possible where you have normal cycles and it just stops. That's not the typical thing, but most people will be going through the transition. So if you're going through the transition, sometimes you will have a normal period. Some of them may be heavier, and then it may get lighter and lighter as you get to the end. So there's no fixed nature of that final period.
Okay, and then the other question was, is it normal to be coughing during this period?
No, it is not.
Okay.
So perimenopause is not associated with coughing.
The other questions too that relate to each other. One is, if someone has had an IUD and they think they are menopausal, kind of what should they do? And then also the other question is, how does taking contraceptive pills affect menopause?
Those are excellent questions. So with the IUD, if you have a hormonal IUD, which has progesterone in it, which is over here, we call it Mirena, the progesterone IUDs can cause your periods to disappear, as in make them very light. So it may be a challenge knowing where you are in your transition because it will mask that. So if you've had the IUD, let's say it's normally for 5 years. So let's say if you're at year 4, you're starting to get a few hot flashes here and there based on your age as well. You think it's time to take it out. You can take it out, but you also have to take care that you have appropriate contraception because you're going to need some blood work. You're going to have to observe what happens with those periods if they're going to come back. So the IUD will mask your transition. So it's going to be hard to tell. Also, the birth control pills the birth control pills do not alter the timing of your menopause, but they are going to mask your menopausal transition as well, because they're taking over your cycle. So you're getting these periods every month, which are like false periods from the pill. So in order to know if you're menopausal or perimenopausal whilst on the pill, you'll have to stop and see what happens with your natural cycle. You're going to have to take some alternate contraception, but you will have to come off at some stage to see what your body is doing.
Okay, so a few other questions. Is it normal to have normal, consistent periods but still have hot flashes? And then, are hot flashes restricted to the end of premenopause? Can one have it after menopause itself?
All right. So the upcoming slides will address that.
Okay. So, how do you judge this IDK of bleeding? I'm not sure. Oh, the risk of bleeding if you have an IUD.
So if you have a hormonal IUD, it's actually protective for your uterine lining, because this way, the body makes two hormones, estrogen and progesterone. Estrogen, think of it like estrogen is a fertilizer. It makes the grass in your womb grow. Progesterone is a lawnmower. It sheds the grass, okay? So if you have a progesterone IUD in your uterus, you're unlikely to develop uterine hyperplasia, like precursors of cancer.
Okay, so I'll just ask a few more questions and then we'll move on. Okay. And then maybe we will answer the other questions in the other question and answer period. Somebody was asking about what supplements can I take and what about hormone replacement therapy? Is that
That's all the upcoming slides.
Okay.
Yeah.
Okay, so I think we can move on and then we will ask some of the other questions after you've done the next session.
Perfect. Okay. So what are the symptoms of perimenopause and menopause? These are the 7 dwarfs of menopause: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and cycle. So for all those listening today, you could be one of the dwarfs yourself. You're yet to become one of them. You may be living with one of them, or you may have lived with one of them when you were growing up. In summary, we don't always feel our best, and our tolerance for nonsense is less. So what are the menopausal symptoms we're talking about, and why do we get hot flashes? So the commonest symptom you hear women complaining about is hot flashes. Think of it this way: the body maintains an optimal temperature via a thermoneutral zone. It's like a thermostat. So the diagram on the left depicts that thermoneutral zone, which is wider. So when you wider thermoneutral zone, you can accommodate a bit of temperature fluctuations and still lie within the normal zone. In menopause, that thermoneutral zone is narrowed, resulting in easy overheating, and then you want to cool down, and then you kind of get into this shivering stage. So I kind of describe it like the thermostat is broken. So the whole reason we get hot flashes is because the thermoneutral zone is narrowed and it doesn't accommodate fluctuations in temperature easily. So the menopausal symptoms can be, the onset of menopause is associated with an emergence of number of symptoms, but they vary. So it includes hot flashes, where the woman describes, a heat wave coming over hair, night sweats, which occur, of course, at night, sleep disturbance. They could be associated with poor memory, poor concentration, irritability, emotional lability, and sometimes depression. There are also MSK, musculoskeletal complaints, such as myalgia is just aches and pains in the muscles, arthralgia is joint pain. So muscle pain, joint pain, fatigue. Sometimes there is frequency of urination and urgency, as well as vaginal dryness and a diminished sexual drive and response. So here you can see we can group them into mental and emotional issues, vasomotor problems, which is the hot flashes. Moving forward, if I refer to vasomotor symptoms, it's all the hot flashes and the night sweats. We can have menstrual irregularities, urinary and vaginal change, and also psychological changes. So what is a hot flash? Hot flash is associated with dizziness. Sometimes women describe the intense, feeling of intense warmth coming over them, mostly in the chest and the neck, the face, the arms, the hands. So it's all to do with a thermostat again, which affects your hypothalamus, which is responsible for temperature regulation in the brain. So as a result of of this, the vessels dilate. When we say the vessels dilate, they open up and causes the woman to have this sensation of warmth and sweating. And then after that, the body attempts to cool itself, and then you get into this, you can swing from being extremely hot to feeling very cool. The associated symptoms sometimes are the dizziness, the headaches, the pounding heart, the sweating, and some women actually describe this sense of impending doom, like when they have a hot flash. 20 to 30% of women will seek medical attention, and I'd say here, you may think it's not possible, but 10% of women are unable to work if they don't have these symptoms treated. So how long do hot flashes last is a $1 million question I get in clinic. Because, when a woman starts having these symptoms, she would hope, most people will try to manage with, lifestyle modifications and would like to avoid medications. If they could tell, we could tell them how long it's going to last, maybe they'll see the light at the end of the tunnel. And so I get this question. It's a $1 million question because 60% of women who experience hot flashes, it'll last less than 7 years, but up to 15% will report that the hot flashes persist for 15 years or more. So this is a study that was done looking at women who experience hot flashes. So we know about 90% of women at some stage will experience hot flashes. They begin before menopause and will peak at about year 4. Between year 4, you'll have the peak of the hot flashes, and then the patterns will vary. It's quite diverse. So in this study, there was like 438 women who were experiencing hot flashes, and some of them reported hot flashes lasting for, sadly, up to 20 years or more beyond when it initiated. So very sad. So would say that at least they could last up to like year 15. You can see it starts to go down, but sure, by year 6 to 8, it's declining, but then it can actually persist. Okay.
Okay, so we'll have a few more questions. One is, does having fibroids affect menopause? I mean, either the timing or the characteristics of it.
Okay, so fibroids do not affect the timing of menopause because the timing of menopause is based on the ovaries, depletion of the eggs and the oocytes in the ovary. And so the fibroids do not affect that.
Okay. Somebody also asked, how about contraception during this period?
As in, does it affect it, or do you need contraception?
Yeah, do you need contraception during that time?
So yes, we would advise contraception because, occasionally, generally the egg quality is decreased. So the chance of pregnancies are lower, but it is an inconvenience if it was to occur. And also at that age, as you know, increasing age does increase the risk of chromosomal anomalies. So if you absolutely do not want to get pregnant, then measures have to be taken. So you cannot assume that because you haven't had a period in 3 or 4 months that you're fine, because an egg can be released and you can actually get pregnant.
Okay, the other question is, are cravings part of menopausal symptoms?
It will be coming up shortly. The slides will show.
Okay. And then the other question is, does PCOS affect perimenopause?
Okay, so PCOS, which is polycystic ovarian disease, just for those who are not aware, does not affect perimenopause. It can affect again, when you have polycystic ovarian disease, you have irregular periods. So it can mask your transition. If you already have PCOS and, lifelong, your periods only happen every 3 to 4 months or twice a year. Of course, when you get into perimenopause, you can be pretty confused. Is this perimenopause or is this still my PCOS doing this? But when you do have symptoms and your age as well, it will tell you that this is more perimenopause. So it can affect different manifestation of perimenopause. Yeah.
Okay, so this one is a long question, but I will read it. She says, after my second child, my period returned for about a year and cut off again in my early 40s. My gynecologist found out my prolactin was very high, and I was given some medication, which I can't remember. Anytime I took the medication, my periods came back. After a while, I stopped the medication, and I still have breast milk after one year if I squeeze my breast. Haven't had any periods for over 10 years. I'm 52 now. MRI on pituitary gland was normal. What's the way forward?
Okay, so it's good an MRI was done to make sure that you don't have a prolactinoma or any tumor in the brain that's producing this. But if you have a high prolactin, it can take your periods away, all right? Now, the big thing is the absence of periods per se. If you have a high prolactin and it's stopping you from ovulating, it could mean that your estrogen levels are also low. So you will need some blood work periodically to assess those prolactin levels and your estrogen levels, as well as this FSH and LH, to see if you are in a state of low estrogen, right, as a result of your high prolactin. Because if that is not a good thing for your bones and your heart to have been, deficient of estrogen for a long time, your prolactin was suppressing ovulation.
Okay, so I think the last question for this period, somebody says, I'm taking fibristol. How will I know I've started menopause?
Okay, so fibristol is a medication that's used to treat fibroids. It is taken in a regimen of 3 months on, 2 months off, 3 months on, 2 months off. Now, when you're on it for the 3 months, you will have no periods. But when you come off for the 2 months, you should have a period, because you cannot start your next cycle of fibristol unless you've had a period. You cannot be taking it continuously. So if you take it for the 3 months and you have no period, and you come off for the 2 months intervening and you have a period, then you're not in menopause yet. But if you skip a period when, in those 2 months off, then you could be in your perimenopausal transition. And until you have another period, you should not be starting your next cycle of fibristol.
Okay, so I think we will move on to the next, the next session. But before you do that, can you reiterate the ages for kind of the age transition for perimenopause and menopause?
Okay.
Because some people came on late and they are asking that question.
So the normal age for menopause is about 51.4 in Caucasians. It's a bit later in women of African descent. It could be into your late 50s. The normal range is between 45 and 55. So that's when menopause can occur. If you have menopause occurring or your period ceasing between the ages of 40 and 45, that is early menopause. And before 40 is almost pathological and should be investigated. So the range we're looking at is 45 to 55 is normal. After 55 is.
So last question here. How would you know you've reached menopause if you've had a hysterectomy?
Excellent question. So if you've had a hysterectomy and your ovaries were left in, you will not know the definite timing of your menopause, because the only reason women with uteruses know when their menopause happens is that the ovaries make estrogen, it stimulates the uterine lining, and then they bleed. So you could still be making estrogen, like with your ovaries inside, and you won't know when your ovaries are giving up. Is it important to know when menopause occurs for you or not? Maybe. If you had a hysterectomy when you were 30, right, and those ovaries give up at 40, hopefully you would have some symptoms that would direct, some investigations. But if you had no symptoms, then you very well may not know when you stopped.
Okay, so I think we will move on to the next segment and then answer more questions later.
Sure. So how do we manage hot flashes, which was one of the questions? So there are a few things that can be done. And most of these listed on this slide will help with mild, hot flashes. But if they're moderate to severe, unfortunately, these environmental, dietary modifications and behavior modifications don't always help. So we know that dressing in layers definitely helps. So if you're in the perimenopausal transition or in menopause, most people do not own turtlenecks anymore in this part of the country because there's no way you can take that turtleneck off when you're having the heat wave. So you're going to dress in layers so that you can take those layers off when you need to cool down. You're going to keep the temperature of the rooms cooler. The spouses may not be happy with it, or the significant others, because you want to keep the house at 17 degrees and everyone is freezing except you. Also, cool drinks, fewer hot drinks, because there are some triggers, right? Decreasing alcohol and caffeine intake, exercise. There's some ways that people can do, paced respiration, just kind of, and also cognitive-based therapy has been shown to help in reducing hot flashes. Now, do natural products benefit on relieving vasomotor symptoms? So we're looking at products like omega-3 supplements, ginseng, wild yams, flaxseed, pollen extract, vitamin E. All of these do not help. Now, women spend a lot of money buying over-the-counter products. Like, sadly enough, our wait times in Canada here can be quite long. People wait anywhere from 3 months to a year to come to my clinic. And so by the time they come to see me, they've tried lots of over-the-counter supplements. These things are no more efficacious than a placebo. So anybody who takes a placebo will feel about 30% improvement of their symptoms. So what happens is that people take these preparations and they say, oh, you know what, it worked for 3 months and then it stopped working. So pretty much that's a placebo effect, and these are not therapeutic. So why the buzz about all the herbal remedies, right? The thing is that there was a big study that was done called the Women's Health Initiative, which was terminated in 2003. And just the way it was reported initially sent a big scare through the community of practitioners for women's health. And women stopped taking their hormones and then resorted to taking all these, trying natural supplements. There is general interest in traditional healing, preference for natural products, mistrust of medical options or opinions. But we know that whichever ways we choose to look at it, there's no difference between herbal remedies and placebo. And the fact that something is natural does not mean it's safe, because if there's an extract from a yam plant or a soy plant, by the time it goes through those processing stages and it's given to a woman to take, it's marketed as being safer, but it's not always safe. And there could be interactions with medications that women may not be aware of. So this is just a slide showing the herbals, soy botanicals. This was a study done with a preparation called black cohosh. It's over the counter, and it was given to women. The multi-botanicals had some soy and alfalfa roots and a bunch of things in it, with licorice and other components. And then there was a multi-botanical combined with soy. And then hormonal therapy is their one with the red line. And you can see there that hormonal therapy was the only group that had a statistically significant reduction in the number of hot flashes that the woman experienced. All the rest are bunched up on top there where the hot flashes were persisting. So there's limited efficacy with these agents for treating hot flashes. So the most efficacious treatment for hot flashes, proven efficacy, is systemic hormonal therapy. I say systemic because you take it as either a pill by mouth, a patch through your skin, or a gel through the skin to get into the bloodstream, into your system. That's why it's called systemic. And that's the best way of treating hot flashes. When we use hormone therapy, in the past, they called it hormone replacement. We've gone away from that term because we're not looking to replace the hormones to a particular level. We're using it to treat the symptoms. So it's called hormone therapy. So the aim is not to replace, when I say endogenous, that's the internal production of hormones, is not to replace those hormones completely, but it is to relieve symptoms affecting a woman's quality of life. So the indication for hormone therapy is vasomotor symptoms affecting a woman's quality of life. If you have hot flashes and it's not affecting your quality of life, that's fine. We don't mean to medicalize the whole menopause transition, but it can be a problem for some people. Systemic hormone therapy also has some benefits for prevention of osteoporosis. If we give the right dose of hormones, we will have over like 80–90% of women will have resolution of their symptoms. Now, there are some non-hormonal medications for hot flashes. Common ones I've written here are gabapentin, which is used originally formulated to treat epilepsy, but we use it a lot to treat women with chronic pain, fibromyalgia, and it's given in 3 divided doses. It can cause about 75% reduction in hot flashes, but it does have some side effects. Clonidine is a antihypertensive, also used with side effects of dry mouth, constipation, fatigue, restless sleep. And then the SSRIs and SNRIs are medications, newer antidepressants that are used for anxiety/depression. We don't require very high doses actually to treat women. Just low to moderate doses can also help resolve hot flashes. These non-hormonal medications are ideal for women who should not or cannot take hormones because they have contraindications to hormone therapy, or women who are fearful of hormones, but they should not be, and this is what they prefer, that's also fine. Now, sleep disturbance is another issue that women may experience in menopause. It's common with age anyways, more common after surgical menopause because of the abrupt withdrawal from estrogen in the one's body can trigger it. And it's more prevalent in women and more in Caucasians, less in Asians. It does happen in Africans for sure. So how do we manage sleep problems? So we need to rule out pre-existing health problems like women with sleep apnea, a condition that causes them to wake up frequently at night, can be the cause. We want to avoid nicotine products, alcohol, decongestants, and eating late, like at bedtime. Then the principles of good sleep hygiene. Regular bed and waking times may not be practical if you're an OBGYN, but so be it. Dark, quiet, comfortable, and a cool sleep environment, comfortable mattress and pillows, and use a bedroom only for sleep and sex. So no TV watching, which kind of wakes up your brain before you're trying to wind down. There are some herbal remedies. One is called valerian. There's melatonin, and chamomile is just used to make tea and stuff just to relax. And those can provide some minimal relief. So estrogen therapy in menopausal women does improve sleep quality in the menopause. It's likely impacting sleep independent of hot flashes, but it also will help resolve the hot flashes. So if you're waking up because of a hot flash, then if the hot flashes are treated and they disappear, then your sleep also will improve. So it reduces the sleep latency, decreases the amount of nighttime awakening, and the number of frequent awakenings as well.
Okay, so we have a few questions here. One is, you mentioned cognitive-based therapies. What are those? Can you just elaborate on those?
Yeah, so that is when you would need a psychologist who assesses in detail your life situation, and then almost like helps you, what's the best way to put it?
To cope?
To cope, yes, to cope, and gives you strategies for coping, with those, which is really psychological based, right? So it's almost like learned behaviors, like improving better behavior patterns that could be affecting the symptoms. So let's say if it's stress or anxiety that's causing your hot flash, because there's exacerbations, right? So if you're stressed, your hot flashes will be more intense. So teaching you how to manage your stress and anxiety, and as such, it may translate to improvement of the symptoms. Again, this is only for very mild cases that have that underlying, predisposition. But otherwise, most people, if it's significant enough, this will not work.
Okay, so 2 questions in one on hot flashes. So somebody says that her hot flashes got better on a keto diet. Can you comment on that? And then also the question is, do hot flashes come and go? So can a woman have hot flashes and then have long periods where there are no hot flashes and then have them again off and on?
Yes. So one, that is very common in the perimenopausal transition, but we also have women who are postmenopausal and would report, when my period stopped, I never had issues. And then 3-4 years later, the hot flashes started, right? And again, what are the stresses that may be bringing, the hot flashes on? If women go through stressful periods, the hot flashes may be more intense. So yes, they can be on and off over time. What was the first question, Jonah? I missed that.
Hot flashes got better on a keto diet.
I do not have any evidence that hot flashes improve with a keto diet. If you, to be able to say that works, you need to have a good study, or it could be either a randomized control study or even in an observational study where they take a bunch of women, put them on a keto diet, don't put the others on a keto diet, and you watch them long-term to see if it's improving. The question is that, were your hot flashes going to get better anyways? Because we did see that, it varies. The duration of hot flashes varies from woman to woman. So it's most likely not the reason why the hot flashes got better.
Okay. Next one is, can you elaborate on the risk of cancer with taking a hormonal therapy, and how long can you stay on hormonal therapy, and what are the contraindications?
Okay, so that is another huge talk. I'm just going to touch on it because I had to take those slides out because that's a whole different thing we can look at another time. But hormonal therapy, so we do a risk assessment. So depends on the age and the woman's underlying risk, right? So we know that if women have to go on hormones, and they do go on hormones in the early, it's important to go on hormones within 5 to 10 years of your menopause, of ceasing your period. Because the longer you go without hormones, actually, you start to deposit plaque in your coronary vessels, and the addition of hormones on top of that plaque can cause ruptures. So there's a critical window within which you have to go on, which is within 10 years of ceasing your periods. So that's one thing to factor in. Years ago, we used to say 5 years of hormone treatment and you're off, that's it, we cut you off. That has been debunked now. Women can stay on hormones as long as they wish, if they're still symptomatic. But after 5 years of use, the risk of breast cancer starts to go up slightly. But that's also based on underlying risk factors such as family history, personal, risk factors, which we will look at in other slides. So yes, you can be on hormones up to 5 years relatively safely, and even beyond. Yeah.
And what are the contraindications?
So the contraindications for hormone therapy are any active thromboembolic disease. So if you have a stroke or a blood clot, presently or in the past, you cannot be on hormones. If you have any undiagnosed genital bleeding, so if you have vaginal bleeding that hasn't been investigated, you cannot be on hormones. If you have, you can actually be a smoker, surprisingly, and you can be on hormones. Active liver disease is also a contraindication. Those are a few, there's a whole list of them, but
okay, so last 2 questions. One is, so what do you do about forgetfulness? Is there something that you can do about that?
So a few things. Women may be forgetful. I think you need to look at the underlying potential causes. So one thing is this: if you're having a very poor sleep quality, okay, that affects your ability to retain information and acquire information. So how is your sleep? Are you still very symptomatic at night, right? Is it the chicken and the egg scenario where you're sweating all night, so you're not sleeping well, you wake up tired, so your focus is low, your concentration is low, and then your cognition is also low? That's one possibility. If there is no such, if you're not symptomatic and you're having issues with your cognition, of course, we also need to be assessed, right? Because there are some families where there is a history of dementia, right? Do you have diabetes, hypertension? Are you having some microvascular issues going on that's affecting your memory? Short of that, if it's just menopause doing that, sadly enough, you just have to keep stimulating your brain. So you just have to keep doing tasks, like be it jigsaw puzzles, crossword puzzles, things like just keep stimulating your reading. And you have to leave yourself notes, like reminders. You have to make notes on everything. And that's the way it is, because sometimes you cannot change that.
Okay, so one last question before we move on to the next segment. There's a notion that menopause causes fibroids to shrink or get smaller. Is that true? And anything you have to say about that?
That's very true. So fibroids love three things. Fibroids love blood flow. So if you have good blood flow coming to the uterus, the fibroids will grow. If you have estrogen in the system, the fibroids will grow. So fibroids will shrink. The treatments we use for fibroids is either block the production of, the effects of estrogen on the fibroids, or sometimes there's procedures we do to cut down the blood flow to the fibroid uterus to make it shrink. And menopause, because you're depleted of estrogen, you're kind of depriving the fibroid of its source of food, so it will shrink. So fibroids can shrink by up to about 40% after menopause. And any fibroids that grow after menopause are a concern.
Okay, so I think you can move on to the next segment.
Okay. So premenstrual syndrome is the next thing that women have to deal with in the perimenopausal transition. So what is premenstrual syndrome? What we call PMS. So it's characterized by emotional and behavioral signs and symptoms, varying from anxiety, sometimes a depressed mood, crying spells, mood swings, irritability or anger, appetite changes and food cravings, which somebody asked about, sleep problems, concentration, and change in libido. There's also physical symptoms that the woman may experience, such as joint and muscle pain, headaches, fatigue. There's fluid retention from those high levels of progesterone, right? Period, bloating, breast tenderness, constipation, diarrhea. So this slide just shows patterns of PMS, where the chart on the left, the menstrual period starts on day 1, where you see all the numbers line from 7 to 28. So the period starts, on day 1. And for some women, the premenstrual syndrome will occur right there. So right before the period, about 7 days before. For other women, it can start like mid-cycle, just around ovulation. They can have all these PMS symptoms. For other women, yes, mid-cycle as well, and then peaks. For other people, it's even coming much earlier, around day 7. So it's quite varied. But the woman will endorse all those symptoms we spoke about. So what is the relationship between PMS and menopause and the perimenopause? So a lot of the symptoms that women experience for PMS can happen in the perimenopausal transition, and it's similar, so it can make it confusing. But the problem is that if you suffer PMS, when you're going through the perimenopausal transition, that can actually be worse. So they'll note their symptoms intensify, and they'll notice that there's more bloating, irritability, headaches, and it can get worse right before menopause. So how about mood and cognition? So we talked about a bit of that earlier, where women can endorse symptoms of anxiety, irritability, depressed and labile mood. One of the prevalent mood symptoms during perimenopause is irritability, tearfulness, anxiety, depression, labile mood, lack of motivation or energy, poor concentration and sleep. I get more referrals for perimenopausal transition problems than even women who are already in the menopause, because this can be a very difficult stage for some women. So women who have never been diagnosed with depression or anxiety can actually develop de novo anxiety and depression in the perimenopausal transition. And that is often due to the hormonal fluctuations. When we looked at the earlier slides, we saw how the periods can come every 2 weeks, and every month, and every 6 months. So the hormones are all over the place. The estrogen levels are fluctuating, and that can trigger de novo mood disorder. So people who have never been anxious or depressed can develop that. And people who already are anxious and depressed on medications can realize that now they need their doses adjusted, they need more medications, they need alternative treatments because perimenopause is really affecting their ability to cope. So these are the pathways that can lead to depression in perimenopause and menopause. It can be complex, a combination of physical and emotional symptoms, because as you can see here, there's different pathways where the depression may be a direct consequence of the hormonal instability, which is what I described with that with this arrow here. So just that hormone fluctuation can lead to depression, or hormonal instability leads to hot flashes. Guess what? You're not sleeping well. Poor sleep leads to depression, right? And then there's the context-related life stresses, right? So guess what? At the age when women are going through this, they have children who are often like in their teenage years, or aging parents with significant stresses, and that can also trigger depression. So it's quite complicated. So the issue is to really be able to identify that this is happening to a woman, so being aware that this could happen and seeking the necessary help. It always saddens me because I remember when I was like in medical school, one of our friends' mothers, it was very sad. She actually, people say, you know, she went into menopause and then she got crazy, like, you know, but I now think of it and I just find that so sad because it affected her marriage, her career, and it was a very sad situation, and that could have been treated. But again, knowledge is power. So this is what I was talking about. So this is women with new onset depression, right? First episode depression during the menopausal transition. You can see that actually women who experience hot flashes during that transition are also at increased risk, right? So in premenopausal women, that risk is perimenopausal women a little higher, and then perimenopausal with hot flashes even higher. So there's a few things that can be done to help keep those mood swings away. Definitely exercise. It's a good thing. Koba, our class president, will attest to that, and he is a motivator when it comes to promoting women to exercise. So lifestyle changes, right? So regular exercise, relaxation. Some people use herbal remedies, which have varied results, but some people report improvement. So there's this St. John's wort, and then there's one called ginkgo biloba. So you need to be aware of drug interactions because a lot of these herbal remedies have not been tested, and you may be on some medications that if you take these remedies, it can interact with it and cause problems. So you need to be careful. You should seek evaluation from your healthcare provider, appropriate counseling, and of course, there are always prescription therapies like antidepressants and hormonal. I get referrals from psychiatrists because they have challenges treating their patients who are in the perimenopausal transition, where like they've treated them with medications for a while, which was working, and now they've adjusted medications, they've added on medications, and they can't seem to get control of the symptoms. I get referrals for these, and hormone therapy does help in selected cases.
Okay, so there are not very many questions here, but one question is vertigo a symptom of menopause?
No, it's not.
Okay. The other question is PMS and menopause itself with associated effects on memory, mood, etc., do have a negative impact on behavior in the workplace, but colleagues may not necessarily understand. What recommendations do you have for coping in the workplace?
All right. So this is where I love it when women come with their partners or the people that live with them, because when I take the questions and I ask, how is your mood? And then she'll say, okay. And the person sitting next to them will say, not okay. So I think awareness is a big thing. We know that this can have an impact. And if you don't have, again, your cognitive behavioral therapy ways to cope, then you need to seek treatment for it. And if you are the one who's going through this and your interactions at work and, you know, your coping strategies are failing, then you should get help. If it's other people, then there's not much you can do because they have to get help for themselves. And we've talked about how you can get help, right? Like, you know.
Okay, so another question is, I think you've answered this already, but you can answer it. Do all women get hot flashes during the transition period?
No, not everyone. So some people will have a smooth ride, other people will have a bumpier ride. So
okay, and then what exercises should I not do?
So there's no limitation on exercises you cannot do based on your underlying health condition. So if you have back pain or a slip disc and there's things you should be aware of, then that's what you have to do. Of course, you have to make sure you're not hypertensive and going to exert yourself to get a stroke or, a cardiac arrest from, an untreated underlying conditions. So of course, you should make sure that you've had your routine checkups and there's no exercise that's off limits.
Okay, so far we don't have any other questions yet. So I think you have one more session, or
no, two
okay,
or three more. Yeah, so we do.
Wow. Okay, so let's keep going then.
Okay, all right. So menopause in the skin and the hair. So estrogen deficiency does cause a woman to lose elasticity in her skin and vascularity. So the skin that's thin and wrinkled, poor healing. There is hair loss for sure. On the areas that you want the hair to stay, you're losing hair, and then unwanted hair growth in the areas that you do not want. So the chin and the chest, you may start getting all these coarse hairs. Joints. So we have aches and pains, very common symptom in menopause, and it's less important for women to maintain regular exercise, 30 minutes, 3 times a week. You need to do both cardio and resistance training. Now, this is a hot urogenital atrophy, which is vaginal dryness for a short form. It's an unspoken concern. So, while menopause-related changes are a normal part of aging, patients and doctors alike need to be aware of the need to ask these questions and volunteer, information with respect to symptoms. So this was a study that was done in Canada, which showed that only 1 in 5 women will talk to their doctor about it. So they'll actually, 1 in 5 women will bring it up. So most people will suffer this symptom silently because it's, they think it's normal, right? It's normal and you suck it up and there's no treatment for this. And doctors also don't ask because, even in this part of the world, doctors are guilty of not asking, but more so I would say that the developing world where, the emphasis is on, long-term disease prevention and stuff, quality of life issues are down the list, but this can have a significant impact on the woman, her sexual life, her, relationships. So you need to ask the question, and women also need to complain if they're having problems. Now, unlike hot flashes, urogenital atrophy will worsen time. So we saw the graph with the vasomotor symptoms, which show that, the peak at 1 to 4 years, and then it can kind of slowly improve over the years. But menopausal, atrophy with the vagina, time does not heal the pain. So we need to remember that it only gets worse. So within 3 years of menopause, 50% of women will have symptoms, okay? So this diagram depicts a healthy vagina and a vagina that has changes related to atrophy. So the part on the left with a healthy vagina there, as you can see, the vaginal lining is very thick and there's healthy blood vessels feeding into the lining and causing the lining to remain elastic. So the vagina is an elastic organ. It has folds in there. So this, with the estrogen on board, we keep the elasticity, the folds are healthy, there's good lubrication. Now, this is a vagina that is experiencing atrophy from the lack of estrogen. So you can see here that the lining is thin and dry and there's no blood vessels flowing to that area. Now, sadly enough, with atrophy, women will lose the elasticity of the vagina, but the vagina can also narrow and shorten. So not only are we losing moisturization, lubrication, but the vagina can shorten and narrow. So The term vaginal atrophy has now been replaced with the term called GSM, genital urinary syndrome of menopause. It just shows that the genitals, the vagina, and the urinary tract are both affected by the lack of estrogen. So with the urinary tract, we have we see that, you know, as menopause approaches, actually the bladder has estrogen receptors. So the lack of estrogen causes the bladder lining and its outlets. So the bladder and the urethra all to become thin. So with this, women may wake up, you know, may start to experience pain with voiding, with peeing, which is called dysuria. They may start to have frequent trips to the bathroom. When they have an urge to urinate, it can be so strong that they cannot hold it. They can wake up several times at night to urinate, called nocturia. They can have leakage of urine when they sneeze, cough, laugh, which is stress incontinence. And then they can suffer from recurrent urinary tract infections. Okay, so that's what happens in the bladder. And then in the genital tract, women will experience dryness, burning, itching. Now, a woman does not have to be sexually active to actually feel the effects of dryness from menopause. They may describe almost like a sandpaper-like feeling in their vulva and their vagina. It may be itching. Beware, not all itching is a yeast infection. So itching after menopause, you need an assessment. Actually, when the tissues don't have any estrogen, yeast infections do not grow in an environment without estrogen. Unless you're diabetic, which puts you at risk, yeast is not likely to grow in the vagina after menopause. So if you have itching, it's most likely some degree of atrophy or dryness causing it, but also you need to be examined because there are some immune skin conditions of the vulva and the vagina that can result in itching. Dyspareunia, that's women who are sexually active, pain with sex. So these women will kind of, if they're being educated or they have the knowledge, they will then present with these complaints, and then bleeding after intercourse, and then abnormal vaginal discharge. So a woman will have vaginal discharge at different times of its cycle when you're you know, premenopausal, but after menopause, you can have some kind of vaginal discharge that's not healthy. You don't have an infection, but the dryness of the tissues causes the tissues to produce this unhealthy discharge. So what I describe to my students is I normally say that a dry vagina weeps. So if your vagina is very dry, you can have some discharge. It doesn't mean that, you know, you're wet, but it's actually abnormal discharge. So here are some healthy tips for the vulva and the vagina. We should avoid harsh soaps. And also people use a lot of contact irritants on their vulva. I mean, the referrals for this condition to my vulva clinic pays my rent in the clinic. Shaving, waxing. There's this craziness about a hairless vulva. So people are shaving, they're waxing, they're doing laser treatments on their vulva, and these can be significant irritants. Instead of shaving with a razor, it would be better to shave with a clipper, like what the men use for to trim their beards, because it will keep the hair trimmed, but not cause the vulva to be hairless, I mean, because as the hair is regrowing, then there's a trigger of itching and scratching, and then that generates all other problems. We need to drink more water for hydration, non-chafing, breathable underwear, no underwear at night when you're not having your period, allow the area to air off, avoid dampness. If you have bladder leakage, wear the right absorbing pads and avoid dampness. Avoid mini pads. Some people are in the habit of wearing panty liners all the time. Why do you worry? Because I have discharge. Wear cotton underwear, wash your underwear. The mini pads, you're giving them business. They're just kind of causing the moisture to be trapped on your vulva, and they trigger other problems. Some of the pads themselves have irritating materials in them that can trigger like an eczema-like reaction on the vulva. And we have to do Kegels exercises regularly. So we'll talk a bit about that shortly.
Queen Elizabeth, wait.
All right.
Okay. So one question here is, does menopause contribute to belly fat? And if so, how can you get rid of it?
All right. So we'll come to that. It's in the latter slides, actually.
Okay. Are panty liners good for younger women?
Panty liners on no account are not good for anybody, Nobody should be wearing a panty liner unless you're having a period. If there's no blood, you should not be wearing a liner.
Okay. Are there any other alternatives to panty liners, or it just should not be used?
It just should not be used. Wear cotton underwear, change it when you have to, no panty liners. It's a no-no.
Okay. Is it better to wash your underwear by hand or in the washing machine? Which one is better?
Okay, so just if you're going to use a washing machine, just make sure that you see all the chemicals. And I'll say that, like having lived in the developing world and here now, we always washed our underwear, hand washed and hang to dry, which I still do to today. You can wash it in the washing machine, but if you do that, just make sure you're using just soap. People use fabric softeners, the bounce sheets, all those drying sheets are all potential irritants for the vulva. So if you're going to wash it in the washing machine, just use unscented soap, double rinse, and then your dryer, if you've used bounce sheets in it for your other clothing, it can coat the drum of the dryer. So if you put your underwear in there, you're getting some of the bounce sheets onto your underwear, which can be an irritant. So unless you can avoid all those chemicals getting into your underwear, hand wash, hang up to dry.
So the other question is, how about if you have incontinence, right? How do you deal with that if you have to avoid panty liners?
That's true. So yes, if you have incontinence, you have to incontinence pads. So there are different kinds of, if it's light, yes, somebody will wear a panty liner when they go out because you sneeze, cough, laugh. That's correct. You will need a panty liner. But when you come home, you have to change it. When you're at home, where you can control things more, then don't wear the panty liner at home, right? You need to change it often so it's dry, because anything that's wet and staying in contact with your skin for a while will be a source of irritation as well. Yeah, so you're right. If you have leakage, yes, you're gonna have to wear one.
Okay, I think we can move on to the next segment.
Okay. So managing vaginal atrophy or dryness, right? So this is completely my acronym. It's not from anywhere. So we need to moisturize the vagina, we need to lubricate the vagina, and we need to use the vagina in order to maintain good vaginal health, which is my love. So moisturization, what does that mean? So moisturizing the vagina can be with local vaginal estrogen. So mind you, this is not systemic hormonal replacement therapy we were talking about earlier. This is just local vaginal estrogen. So we moisturize with local vaginal estrogen, just like you would use, cocoa butter on your skin or moisturize on your skin every day. The vagina needs to be moisturized as well, because with time it dries up. We saw that already. So we can use creams. They come in a tube with an applicator. When we start treatment, we go every day for 2 weeks, and then after that, 2 to 3 times a week on an ongoing basis. So this is not to be used before intercourse or anything like that. It's to be used regularly to moisturize the vagina. The applicator has to be washed and reused. The alternative is tablets we can insert in the vagina. And then there's a ring, actually, that can be changed every 3 months. So that is a hormonal ways to moisturize the vagina, which are the most efficacious. Then there's non-hormonal moisturizers that can be used. They're not actually the ones with hyaluronic acid you see there, and the Replens. In some studies, they have been shown to be equally good. The problem with those non-hormonal moisturizers is that they are over the counter, and they're quite expensive, and they're not covered by insurance plans because they're not by prescription. So unless there's a good reason that a woman should not be using vaginal estrogen, for example, she has undiagnosed genital bleeding, or she has a higher stage of endometrial cancer, or even breast cancer is questionable. In selective cases, we can use vaginal estrogen, but if there's no contraindications, vaginal estrogen is the way to go. Vaginal moisturizers, like the other ones, the non-hormonal ones, can produce a good effect like estrogen, but it will not reverse the atrophic findings. Okay. So these are just some pictures of what we have available here in Canada. So there is the cream here. There's different kinds of the cream. I just had a picture of one. The commonest, which is permanent vaginal cream. I believe that one is available in Ghana. And then we have the tablets called So the tablet is literally preloaded on this applicator. You insert into the vagina, you release it, you throw away the applicator. It creates a lot of garbage, but it's very convenient because with this one, you have to wash and reuse. The vagina is very dry. However, the creams are preferable because they smear better, and you can put some on the vulva as well. And then there's the ring called the E-string, which pretty much has the estrogen impregnated in the cavity of the ring here. You insert this in the vagina, high up, you let go, leave it there for 3 months. It does not have to be taken out with sexual relations. You just have to be able to reach in and take it out and replace it, and also be comfortable with that sitting in your vagina for 3 months. So estrogen in the vagina, it does relieve symptoms. It improves the thickness of the folds, the strength of the vaginal lining, produces natural lubrication, helps with elasticity, and it does enhance sexual response. So that is the moisturized part. So we talked about my love, moisturize, lubricate, and use the vagina. So moisturization is what we did. So how about lubricants? So lubricants, we have multiple lubricants, water-based and silicone-based. The water-based ones are generally less irritating. I put an X by KY jelly because it is the commonest one available, but it's not the best. It dries up really fast. So I always say it dries up before stuff is done. A good one is Astroglide, slippery stuff, wet or liquid. I guess these can be purchased on Amazon. And it does help to enhance pleasure and decrease the friction. What is using the vagina? Continued vaginal intercourse. So when you ask that question, are you sexually active? You're going to get yes. Sexual activity means a myriad of things. So the question is, do you have penetrative vaginal intercourse? Because penetrative intercourse is what is going to stimulate the uterine, the vaginal mucosa. It improves the blood flow to the vagina and helps to keep the vagina healthy. So if a woman does not have a sexual partner, or they live, let's say, apart, right, for whatever situation, if she's in menopause and there's no ongoing stimulation of the vagina is going to narrow and shorten, and subsequent sexual encounters are going to be painful. And then that's a whole different topic. It's going to trigger issues with sexual pain. It's going to affect the libido further, and it's a huge problem. So if women are in menopause and their partners do not live with them, but they will be meeting up intermittently, it's important to use vaginal estrogen. And this is a scenario where a woman will require a vaginal dilator, like a dildo in the vagina, to stimulate the tissues regularly. So when she does meet up with her partner, things are not painful. So urogenital symptom relief. We're talking about the issues with the frequency, and urinary tract infection. So important to limit caffeine and irritants to the bladder, like even carbonated drinks, like be it like Perimenopause or any of the carbonated things, either they're sweetened or unsweetened, can be irritants to the bladder. With age, the bladder tolerance for irritants can be low. So you could have done this your whole life, but now it is a problem. So that's important. Increased activity, encourage weight loss. Vaginal estrogen is the key. Bladder drills, where people feel like, I need to go and pee every 30 minutes. And when they go, there's no urine, they don't pee much. Why is that happening? Because sometimes your bladder can become overactive. So you need to train that bladder to kind of be able to hold urine longer. Sometimes it is a mental thing, but sometimes it warrants medications, depending on what the problem is. With frequent urinary tract infections, that can be triggered by intercourse. So women also may have to learn to avoid, go and pee after intercourse, make sure you're well hydrated, and things like that. And then there's a role for physiotherapy of the pelvic floor based on the symptoms. I cannot get into much of that now.
So the question here may have been answered before, but somebody says, I've been having my periods twice in a month. Could this be related to perimenopause?
That's correct. So that's what we talked about on those initial slides, where the periods can go from once a month to every 2 weeks. And the every 2 weeks one, if you bleed for 5 or 6 days, it's like you're bleeding for 2 to 3 weeks a month. So that could be a problem. So you warrant, it could be a sign of perimenopause, but the important thing is that we need to make sure that you've had at least a pelvic ultrasound and a uterine lining is not over a range that we're worried about. And if it happens every 2 weeks, but you're not hemorrhaging, then that's okay. It's your normal perimenopausal transitioning that's occurring.
Okay. Okay. There are no other questions at this time, so I think you have the last segment.
Yeah. Okay. So, I mean, we've talked about all these things, but the menopause issues we talked about, the hot flashes, the insomnia, the mood swings, the genital health, those are just the tip of the iceberg, right? Those are quality of life issues. But whether you have obvious symptoms of the menopausal transition or you're breezing through, what women should be really concerned about is the long-term effects of estrogen deficiency and aging on different aspects of our body. So when we talk about heart health, osteoporosis, colorectal cancer, and other cancer risks. So we talked about this phase where we have the irregular bleeding, the hot flashes, the final period, the vaginal discomfort, the bladder symptoms. But then as time progresses, here comes the heart disease and the osteoporosis, right? So what is preventative care for midlife women? We need to have our blood pressure, glucose, your lipid profile, which is a cholesterol monitored regularly, regular pap smears, at least every 3 years. And if you've had abnormal pap smears, you may need to have your pap smears done yearly, right? And even with that, you may need a procedure called a colposcopy, where they may have to examine your cervix further and even do biopsies if they are concerned about precancerous lesions on the cervix. So important to get regular pap smears. Regular mammograms start anywhere from 40 to 50 is optional. 50 and over, for sure, you should be getting your mammogram every 2 years. Based on the findings, you may need mammograms more frequently. Colorectal cancer screening, bone mineral density to test for osteoporosis in selective patients, appropriate immunization, safe sex, and fall-proofing recommendations for women who are much older and have arthritic changes and instability when they move around. So weight management. Are we looking at weight loss, or we're just looking to be healthier? But whichever ways, we really need to work hard to stop weight gain. Now, this is a big issue because our weight gain is driven by almost like our need to be cavemen, right? See food, eat food, too much food available. So we have to be very selective in what we put into our mouths. So weight gain during menopause is very common. It's not inevitable though. The average weight gain by textbook says 2.2 to 4.1. I see way more. So 50% of women aged 45 to 64 are overweight or obese. The risk associated with it, cancer, cardiovascular disease, diabetes, right? So meal balancing, I mean, what are we looking at here? Now, I just want you to know that I don't want people to be calorie counting or restricting calories, because that's not a way to maintain weight loss. If you want to lose weight, you can do that, but it's a lifestyle. What goes in and how much you burn, right? So if this is kind of an idea, if you want to maintain weight and you don't want to gain based on your level of activity, women in the postmenopausal range will need just about 1,800 to like 2,000 calories a day, right? Important to have like a good balance of protein, starch, and vegetables, right? Ideally, half of the plate should be vegetables, a quarter starch, a quarter protein. But I know it's the other way around. 3/4 of the plate is starch, and then often a little bit of protein and vegetables. So we have to be very conscious about this if we can to help us maintain weight. People come very frustrated because they tell me, since I went to menopause, I've gained 25 pounds and I'm doing everything, I can't lose it. But what I tell them is, if you weren't doing what you're doing, as in if you weren't exercising, if you weren't watching eating, you will be gaining, 2 to 5 pounds every year. But because of what you're doing, you are now maintaining your weight. So that's an achievement. So yes, you may not be able to lose what you gained after having babies, and now perimenopause came along, you gained some weight, and now you are stuck at this weight. But if you are not gaining further, you're winning. And if you can lose, that's great, but may not always work. So this is what we're looking at here. So this calorie count thing is just to give us an idea of what we're putting into ourselves. And I like it because sometimes you really underestimate what you're eating. You know, that slice of cake that you could have resisted could be almost 500 calories, which is like half your daily requirements. And yet you had breakfast, you had lunch, and now that's on top of it, right? So it's just to give us an idea. So this was a little thing I did here. Here's a slice of Fanti Kenke. So there is this app called MyFitnessPal app, which actually has all the foods, like all the Ghanaian foods. There's kenke on it. What I see though is that sometimes it's not accurate. The variation is very huge. But I looked at this, this was kenke I weighed at home. This is just a small kitchen scale I have, relatively inexpensive. This is about 101 grams for this one slice of kenke, all right? Looking at that table on the left, which I took from the MyFitnessPal app, I just put in kenke, right? You can put anything, plantain, you can put anything. It'll give you how much calories that you could be ingesting. So for the Fanti Kenke, the Nkulenu brand, it says 100 grams of kenke has 140 calories, okay? And so this one slice is 100 grams. So if you're eating like 4 of those slices, right, that is 400, 140 times 4 already, right? That's about 600 calories for just your kenke. You haven't added anything on, and that's just one meal. So it gives you an idea. So what I find helpful, and I tell my patients to do, is why don't you just do, like, don't do it forever, do it for a week, okay? Try and track what you're eating, breakfast, lunch, dinner, and you realize, holy smokes, like I'm actually ingesting maybe 3,000 or 4,000 calories a day, right? So there's no way you're going to lose weight if your caloric intake is so high. So this is just a guide. You're not meant to do this for life, but just to put you in that time, the mindset of really watching what's going in, right? We want to make sure that we're eating more whole grain. So brown rice instead of white polished rice is helpful. You can have white rice for sure. Time to time, you're having your mutio, you can enjoy your white rice, but brown rice when you come, whole grain bread, no added sugars, right? So apart from the sugars and fruits, right? You don't want to add sugar to anything else. So all the cakes and all the lovely things are all added sugars and could be contributing to the waistline, right? Oatmeal, very helpful. And one thing we also should be aware of is that in menopause, when women gain weight, sadly enough, it is not evenly distributed. So when you were younger and you gain weight, it's going to go a bit into your bust, into your waistline, into your hips. But guess what? Now, when we gain weight, it all goes into the belly. So here we are. Our limbs could be smaller, our arms could be smaller, but then we have the belly fat. And all those of you in internal medicine and all the other specialties, you know that truncal obesity, which is a central weight gain, is what increases the risk of cardiovascular disease even more. So that's always something to note, that it's not distributed evenly. So if we want to improve our health overall, we need to exercise 150 minutes a week. If you want to lose weight, you have to up it. If you want significant weight loss, even more. And then after you've lost weight, if you want to maintain, it is a balance of exercise, what goes in and how much you burn. Now, cardiovascular risks here. Can we have a look here? So number one cause of death, women, is cardiovascular disease. It happens about 10 years after menopause. So by age 75, 1/3 of women are affected. 1/6 will unfortunately die from this. Why is this happening? Because when we go into menopause, the estrogen loss does start to affect the profile. So the good cholesterol, HDL, goes down, the bad cholesterol goes up, plaque formation, systemic effects, and then there's the weight gain and all the other conditions that go with it, right? So when we look at heart disease, what can we do? We have the modifiable risk factors, and then those that we cannot modify. Genetics, unfortunately, we can't change that, right? Increase in age, we cannot change that. Personal history, if this has happened already, you can change it. But the things that you can change, stop smoking. If you have diabetes, good control, maintain the weight, treat the high blood pressure, avoid and treat the high cholesterol. The abdominal obesity is a huge thing there. Physical inactivity, and then stress and menopause. Those somewhat modifiable. And then the last segment after this, I think.
Okay, so there are a few questions here. How do you overcome the cultural and religious taboos that comes with sex? So, for example, in Ghana, the thought of people using vaginal dilators and things like that may be frowned upon.
Yes.
And so how do you overcome that?
So that's an excellent question. It's not only in Ghana, it's even here. If you have people that are very conservative. So I have a lot of even like cancer survivors in my clinic, right? So they've had all sorts of cancers, and some of them have had local pelvic, radiation. So the vaginas are actually narrow, they have strictures, or postmenopausal women who did not have this information. So sex is now painful and they're trying to get things back on course. So I ask them to go buy dilators. Now they can get it online, okay? And it can also be purchased in the adult store. So there is a sex store, an adult store that I send my patients to particularly. And I say, go to this store. They are aware that I send a lot of people there for medical reasons. It's not just for self-pleasuring, which if you choose to do, there's nothing wrong with that, but go there and you'll be welcome. Now, when you say that it's frowned upon, I think this is where the partners need to understand what's going on. So if you have a woman, your wife or your partner is having sexual pain, and she seeks consultation, and she's now been told to dilate her vagina. If the man understands, it's not like I'm not in love with you, or I don't want this to happen, but I need to stretch my vagina up to where it used to be before you can accommodate your husband, then the partner understanding takes that pressure off you. And there's nothing that is taboo about it if both parties involved understand what's going on and are supportive of each other. How is your pastor going to know you're putting a dilator in your vagina? Good luck. He wouldn't know. So it's really between you and your partner. So this is where communication is a big key.
So, okay, so there's a little clarification. So this person was asking about stimulators rather than
dilators.
Yes.
Okay, so stimulators, so there's so vibrators, okay, come in two kinds. There's vibrators that are just for external, like the clitoris and the vulva, and then there's the vibrator you insert in the vagina. It's the same idea. The vibrator is actually even better than a dilator. It goes in there, it moves around, it improves the blood flow to the area, right? So you can do that for self-pleasuring, and you can do that also to maintain good vulva and vaginal health. So there is nothing religious or taboo about it. Yes, it is a culture has created that picture, but again, it's done in a particular setting. If it's with your partner and you understand each other, that should not be a problem.
Okay. The other question is, can shea butter be a lubricant?
So shea butter, so people use shea butter is not a good lubricant because it's too thick. So when you think of a lubricant, it has to be, so even when a woman uses vaginal estrogen in her vagina to improve the moisture, right? When her body is stimulated, the secretions that she makes are still not like the secretions that she used to make when she was cycling. The mid-cycle ovulation, lots of secretions, that doesn't happen anymore. So whatever lubricant you use has to have a consistency of what your normal secretions used to be like. So some people find coconut oil to be helpful as a lubricant, and that's fine, it works for them. But it doesn't, anything that's not as close to the consistency of your normal secretions is often not optimal. So shea butter is a no, it's a bit too thick.
Okay. So the other question is, you mentioned kind of safe sex, and somebody's question is, what is safe sex and what is detrimental sex? So can you?
Yeah. So safe sex. So we need to be cognizant of the fact that based on our cultural and religious backgrounds, people are often thinking that sex is always in the context of a monogamous relationship, right? But that may not be the case. So you may have somebody who has 2 partners or 3 partners. So you can have polygamy at one go, or you can have what we call serial polygamy, where they have 1 partner today, the relationship lasts a month, the next month it's another person. So they may have 3 or 4 partners in a year. And in that scenario, yes, you're in menopause, but it doesn't protect you from sexually transmitted infections and pelvic inflammatory disease. So if that is the kind of relationships you're in, then make sure that you get screened and those partners get screened, and that you use condoms, for not for pregnancy prevention, but for STI prevention. So that's what I mean by safe sex.
Okay. We don't have any other questions at the moment, so I think we can complete the last segment.
All right. So the other thing I want to talk about is osteoporosis. So osteoporosis, is a condition, it's a skeletal disorder, which is characterized by the bone strength is compromised, okay? And it increases the risk of fractures for the woman. So normal bone is the one on the left where you have, you know, that whole network of bones there looks solid. And then osteoporotic bone is a bone on the right where it looks like cobwebs. The supporting structure is very weak. And that can fracture with impact, okay? And it can be very little to minimal impact can cause fractures. Now, this development of osteoporosis doesn't produce any symptoms. So the aches and pains and the joint aches and stuff that women feel is not osteoporosis, that's osteoarthritis. So you will not know that this is happening until you were going down the stairs, you slipped and boom, you get a big fracture, or you know you're involved in some kind of small injury and then you end up with a fracture, right? That's also when you see women slowly losing height, right? Because in the vertebrae, like if there's osteoporosis, it can actually, they can get fractures in their spinal column and the bone can compress and reduce the height of the woman. So the peak bone mass is built between 20 and 30, and then it's maintained after in men with very little decrease. And then the woman, as you can see with time, there's an increased risk from the lack of estrogen. Now, the good thing though is that African women of African descent are, they are at risk for this, but not as high as Caucasians. So areas we look at are the hip, the spine, and the wrist are common areas of fractures. If a woman ends up with a hip fracture in her elderly life, it's a big problem because the immobilization, subsequently development of blood clots and whatnot, and death is high. So a 50-year-old woman has a 40% chance of fracture over her lifetime. So how do we prevent osteoporosis? This calcium is very essential for good bone health, all right? Now, the recommended intake for calcium, and I'd like to mention that if you're getting enough calcium in your diet, you do not need any extra calcium supplements, okay? So if you get enough calcium in your diet, no need for extra supplements. So you would, there's a website, Osteoporosis Canada. If you go onto their website, there's a page that shows you the different food portions and how much calcium it contains. So let's say, you know, a glass of milk contains this much. Sardines, you know, some leafy greens, things like that. So that will give you an idea of how much calcium you need. So in the postmenopausal woman, she needs 1,200 milligrams a day, and that's a combination of diet. If you cannot get in your diet, then you can add on supplements, okay? But if you can get in your diet, that's the best way, all right? And then vitamin D, thankfully in the tropics, exposure to sun, you need 20 minutes a day. But again, you know, that could not be happening because in this era of, you know, driving to work and into a building and then back into your car and home, you may not be even getting that exposure. But more so those that live in this part, in Canada, the US, you know, where there's longer, in the parts of Canada where we have longer winters and shorter days, most people are very deficient. So I recommend wherever you live, 1,000 international units of vitamin 3 a day with appropriate calcium intake will help with osteoporosis prevention. And then exercise and balance training, and can't emphasize that more. It helps to improve coordination and greater muscle strength to limit the risk of falls. You know, one big thing that happens as women age is the loss of muscle mass. So what happens is when you, just by you gaining fat and whatnot, you lose muscle mass. So we always talk about arthritis or osteoporosis, but sometimes we forget to talk about the muscle mass. So your muscles will atrophy. They'll kind of, you know, waste away. And then if you don't have good muscles to support your skeletal structure, your balance is poor, more risk of falls and injuries. So just a quick touch on breast cancer. It is the leading cause of cancer deaths after lung cancer in Canada. breast cancer is the most common cancer in Canadian women. In Ghanaian women, breast cancer is number 1. Number 2 is cervical cancer, then ovarian cancer, and endometrial cancer. So there are some risk factors. If you have 2 affected first-degree relatives, that increases the risk. Obesity, excessive alcohol intake. We talked about being on hormone therapy for more than 5 years. Things like having a child later in life will also increase the risk. And then those that are below the horizontal line are actually the protective factors, right? So exercise, delayed menopause is a risk because more estrogen to your breast, right? So exercise is protective. Okay. And egg is also protective because your estrogen levels are cut down, so they're not stimulating your breast as much. So some major risk factors that we look at are increasing age, and if you have a family history of a gene called the BRCA gene, that can be a risk factor as well. So just things to take note of, okay? And then here are some resources for you. I'll just leave the slide on for a second if you want to take a screenshot of it. And so in summary, with the appropriate medical knowledge, we have the ability to control the modifiable determinants of our health and live a healthy and fulfilling life after menopause. Thank you for your attention.
So thank you very much. Yeah, this was very eye-opening and very educative. There have been several people, saying thank you for this, and I think this has been 2 hours well spent, and the questions have been really very stimulating, and the answers have been brilliant. I think for those who are asking about this presentation, it was streamed live on Facebook, on my Facebook page, so Jonathan Laye. So if you are not my friend, you can ask to be my friend, and then you can have it there. Now, there's been asks about doing this on a regular basis. I think we have Dr. Matthew Che on, who did a talk on male sexual health today on Joy FM. And it would be good to have another session like that, and we can have this as an ongoing thing. So people are asking for this, and so I think this is really great. Koba, do you want to say anything before we end up? Is Koba still on? Okay. If not, then thank you all for.
No, Koba is here.
Oh yeah. You want to say any final words?
Yeah, it's just been a terrific evening, great 2 hours. Yeah, we are very, very grateful. I can see Colonel smiling. So we look forward to another session with Matthew, like you said, and then I think is going to come back. It's a part 2. Yeah, am I right?
Yeah.
And then we'll all fill in as we go on.
Yeah.
I guess somewhere along the line commented on some of the things when it comes to exercise, balance training. So we'll be putting such sessions in as we go along, and we'll get a complete picture.
Yes, and I think one good thing that I need to mention here is Koba's book. Koba, can you talk about your book? Because that has really very good information for not just around menopause, but around kind of just healthy living in general.
Yeah, so the book, Unraveling the Essentials of Health and Wealth. I believe what we've tried to do is to talk about everyday things that affect our health. The aim is to let us take responsibility for our health. And it's easy to get one, and just swing by on Amazon, booknook.store. And I also make it available. Maybe, Jonah, I'm going to put it on your site, on your Facebook page, since you'll be getting many friends. But it's a book I think we shouldn't just gloss over. I wrote it, but I'm very proud of it. I think it addresses everything that we need to know that will give us a holistic life, you know. And we should always know life is not just about being healthy. We need to enjoy it as well. We should make every day count. Victor, I know you agree with that. Yeah, so.
Okay. So thank you all for coming. And, you know, for those who are not my friends on Facebook, if you want to, you know, be my friend, then you can get access to the video to this presentation. Thank you. And we will come back hopefully in a short period of time with the next segment of this, as we mentioned. Thank you, everybody, and have a good evening.
Thank you very much. Yeah.
Thank you. Yeah, thank you.
Thanks, Jonah.
Thank you very much. Yeah.
Thank you.
Hey, is that Griselda's face? Show your face, Griselda.
Yeah, it is.
Thank you. God bless you.
Thank you.
God bless you. Bye.
So much.
Thank you, Brenda.
Jonah.
Yes.
Well done.
Hey.
You all.
Hey,
Jonah, hi.
hi.
Hey, Patricia.
Yes, great seeing everyone.
Hey, Katrina.
Party is on. And this party is on now.
Is that
Hey.
Annie.
Hey, Charlie Howe.
Matthew.
Yeah.
Good to see you all.
Griselda, I need your cutting diet.
Brenda is there. Brenda is there.
Yes,
She was there.
Brenda came late.
Everybody.
Hey, Jonah.
Yes.
Jonah.
Hey, Kobe, not boy.
Oh,
That's someone.
Hey.
really, really good.
Hey, Uncle Nana.
Well done, yeah.
Yeah, thank you very much.
Where's
That was very
I
good.
can't hear her.
This your brain on the die cry.
Hey, have you seen my message?
Where's the message? I haven't seen it.
It's very scary. You know, the forgetfulness is very scary.
What is
The
scary?
forgetfulness, you know, the forgetfulness, it's like cotton wool. It's like cotton wool in your brain.
Tell me about it.
You know what the cause is, but you still get worried, you know?
You have the note app on your phone.
Yes. Yeah. No. But I think the main thing is talking about it. If you talk freely about it, you realize that most of the other women have gone through that. And then you feel better because you're not hiding anything. You're not hiding away. And it reduces the anxiety. So I think people just need to talk more about what happens to us naturally, really.
Omega.
Okay, so
Hey,
bye.
so,
Take care. Hello. Bye.
but Jonah, you know your house abandoned me. She doesn't have something here again, no.
Why?
I'm treating menopausal women. What do I have to do?
Hey.
That was great. Yeah.
Arnold, hello.